have to wait until the end of my presentation to find out what's an orthopedic surgeon doing in an oncology meeting. Enhanced bone healing and immunomodulation is my topic. And I'm talking about fracture healing or rapid bone repair in closed long bone fractures. I guess fracture treatment started in antiquity, but did not have significant progress until the turn of the 19th to 20th century, when eventually both internal and external fixation has been developed. Ironically, it was the surgeons from the empire that is responsible for both world wars who significantly advanced the technique of fracture repair, fracture fixations. We are talking about at the late of the war, Second World War, that is, the British and American eventually developed a proper fixation of fractures, closed fractures, not involved in multiple injuries. And eventually the Swiss developed the final fixation of bone. Again, I'll repeat, we're talking about closed fractures, and eventually, after the internal fixation was developed, although the external fixation with a young man in a little place in Azerbaijan was developed. Fracture treatment has changed significantly at the end of the 20th century and definitely more in the beginning of this century. From a simple repair of fracture, a hormonal concept, or a development of the inflammatory concept of a fracture came to be complicated by an immunological description. It is a new branch in medicine, the osteoimmunology, that is now responsible for the bone repair studies. I repeat again, this is a closed fracture, traumatic fracture, not related to metastatic lesions, and is expect the immunotherapy to have any effects. A number of publications in this century on repair of the bone on the immunology is really staggering. Literally thousands of papers have been published until a definite theory of an enhanced bone repair on the immunomodulation came to be. The authors intend to describe the pro- and anti-inflammatory cytokine, interplay with bone repair, invasion of the lymphocytes, particularly the macrophage, or the more sophisticated form, the osteomach, all originating in mesenchymal cells. If you have in front of you the 3 stages of repair of bone, I hope you have in front of you the inflammatory stage, macrophage, C cells, cytokine secretion that eventually leading to the middle stage, in which soft callus and eventually hard callus of the bone is developed. And finally, a regeneration stage in which osteosynthesis is the final good result. Many attempts have been developed for pharmaceutical intervention in enhancing bone healing. Experimental and even clinical trials None of them led to a significant shortening of the healing time of bone fracture. They were all influenced by diabetes, muscular dystrophy, malnutrition, polytrauma, immunodeficiency, renal disease in geriatric period. But in general, it was accepted that 17 weeks would be an average for a bone healing of closed fracture not related to metastatic lesion. And if that exceeds, the non-infected, not open fracture would be compromised up to 35 weeks of recovery of long bone. I would only commit myself to 3 out of the 1,000 papers that have been published on bone healing. It was a modulation in 2004 of inflammatory process and bone healing that established definitely the relationship between the T cells, the soft callus formation leading to osteoporosis, and eventually the regeneration of bone following an inflammatory period. This study of Nagahama established the interplay between immune and bone cells, so very essential for bone repair. Some 7 years later on, also in this century, in 2011, fracture healing is accelerated in the absence of adaptive active immune system, in which led to the minimizing of a destructive effect of the inflammation, will eventually lead to an enhanced osteoblastic and fracture repair. Just this year in 2023, the immune checkpoint inhibitor that we are talking today was found a friend of a foe, osteoporosis. And the definite conclusion was that osteoclastic hyperactivity, early leading to osteoporosis, but eventually increasing the osteoblastic activity and increased bone repair. Our case of immune therapy in bone healing was raised by a case of a very fascinating case in which, at the time, in 2021 December, then a 23-year-old lady, a heavy build, 169 in height, walked in my surgery 2 weeks after a fall in which she landed on her left knee and had a little pain increasing, and on various X-ray examination, plain X-ray, CT, and MRI scan, it was diagnosed a split in a tibial condyle. How she could walk on it with minor pain is very difficult to explain. She walked, however, freely, unsupported, the fracture not immobilized, refused to have any medical treatment and any surgical consideration. She continued her normal activity, including driving and walking upstairs without immobilization. The only possible influence was a lymphedema following a groin dissection performed some 6 months earlier, in which a lymphedema, a swelling of the entire leg with subcutaneous lymph accumulation, was treated simply with a stocking. The lymphedema developed, as I said, after inguinal intervention to remove the glands to prevent recurrence of melanoma on her left leg that occurred initially some 6 years earlier. At the time of that fracture, I repeat again, without any sign of metastatic lesion, was treated by a monoclonal antibody, ICI, called pembrolizumab. The prophylactic treatment was followed after that, and you can see the MRI, X-ray, some 3 weeks following the trauma. One can, in image number 1A, recognize a lateral view of the tibial condyle with fracture, and a 1B image of the MRI, a vertical fracture, literally split of the tibial condyle. Following plain X-ray and CT scan, 3 weeks later, when we already have what we could call a softish bone fixation, the pieces of a bone were held together, and it's difficult to imagine. After 45 years of practice in orthopedic, I cannot tell you how many hundreds of fractured tibia I was looking at. None of them could be able to walk on it immobilized. Last images that I hope you have it in front of you was exactly 32 days after the fall, in which almost complete fracture healing is present. The radiology report on the 4th of January detected a full healing of the bone with minimal discrepancy on the surface of the tibial condyle. This rapid bone healing, unreported as yet in the literature, after hundreds of publications, remains, in our view, the very first case. It is very difficult to consider anything else except the ICI inhibitor that contributed to the rapid healing, and although no definite conclusion could be reached, the mononuclear antibodies, the effect of ICI proteins, remains the only reason to explain a rapid bone healing. Please, the audience, look at the very last image in which we suggested, rather than concluded, that the ICI inhibitor, the pembrolizumab, in the second stage of healing the bone, depressed the soft tissue callus to minimum and enhanced the osteoblastic one that led to hard callus formation. That would be all for us, explaining how an orthopedic surgeon is contributing to this oncological meeting. And I hope I will have commentaries. Thank you.
Dear colleagues, today I would like to present to you my presentation on the topic morphometric analysis of the tumor microenvironment in gastric cancer and areas of morphologically normal membrane in the peritoneal region. The tumor microenvironment is as a surface targeting cancer has attracted great research and clinical interest. This picture shows the complex interaction of various cells of immune microenvironment in a tumor. There are several immune-associated mechanisms that can damage tumors. One of them is carried out by CD8 T cells. Tumor-reactive CD8 T cells identify cancers by recognizing peptide MHC1 complexes that generate through the MHC1 antigen presentation pathways. When recognizing cancer, CD8 T cells continue to see T cells using peripheral or dependent pathway and can also damage tumors provoking inflammation. Cellular immunity forms the basis of anti-tumor immunity. Cytotoxic T lymphocytes play a particularly important role, which is a possible reaction to CD8 and T cells, which can cause the death of tumor-based cells. The degree of infiltration of the tumor by CD8 positive cells is favorable prognostic signs in many types of cancer. In most studies devoted to the assessment of this rate, manual counting is used, followed by an assessment of the average number of cells in several fields of view of the histological preparation. However, this approach doesn't allow us to reliable exclusion process, diagnosis, and crash phenomenon from the analysis, and also doesn't allow us to fully take into account both the heterogeneity of distribution of immune cells in a tissue fragment and the heterogeneity of tumor tissue itself. Due to the higher complexity of manual counting, the introduction of automatic system is required that allows for accurate mathematical analysis and calculate the absolute values of indicated calculating the density of infiltration by immune cells. There is an extremely small number of studies that would include an assessment of the degree of concentration of CD8 positive cells, not only in tumor tissue, but also in the morphologically normal mucous membrane of the peritoneal region in gastric cancer. This direction is important in the study of gastric cancer since immune cells in the areas of the mucous membrane of normal structure resistance to the tumor can affect the process of epithelial mesenchymal transition and metastasis. It is possible that the characteristics of the environment of mucocytes correlate with clinical characteristics and has prognostic significance. What about materials and methods? In this work, the degree of CD8 positive infiltration by cells was assessed not only in the tumor tissue of patients with advanced gastric cancer, but also in the adjacent healthy mucous membrane of the peritoneal region. The assessment was carried out both using the classical morphometric methods of manually counting the absolute number of CD8 positive cells and using the automatic methods proposed in this article for calculating the area activated by CD8 positive cells on a histological preparation using the system. The automatic assessment method reveals correlation between the integration area of the 8 positive cells with a degree of tumor progression and patient survival. The study different samples of surgical material with a size of at least 4 millimeters from 139 patients with a confirmed diagnosis of gastric cancer. An important criterion for the selection of working box was the presence in the study material of type of gastric cancer and adjacent areas of morphologically non-mucous membrane of the peritoneal region. Study included 62 men and 77 women. The average age of the patients was 62 years. The main clinical morphological characteristics, the sample are presented on the following slide. Both women and men were included in the study. The tumor has a different physiological type according to the classification of the World Health Organization. The degree of differentiation different in the presence of tumor embryo in the lymphatic and blood vessels. So has the different status of the rejection margin and the Siemens stage with separate parameters. The number of cases included in the study is shown in this table. During the morphological examination of the tissue on person sections, the following histological regions were indicated by specific localization and structural difference. The central part of the tumor is characterized by a consist of normal cytoplasmic of the tissue understudied the degree of differentiation of tumor cells was at least distant conductive area. The invasive margin is defined as a boundary between tumor tissue and tissue with normal morphology. The mucous membrane of the peritoneal region has a typical histological structure. In all areas seen with the immunochemical marker CD8 reveals an infiltrate of CD8 positive cells. Heterogeneous in degree of representation in different parents of tumor tissue and in different areas of the same adenocarcinoma. In this picture shows the infiltration of CD8 lymphocytes from the central part of the tumor tissue and detection of the morphological normal mucous membrane of the peritoneal region. To describe the differences in the representation of the immune infiltrate in morphologically isolated areas of the tumor and peritoneal region, and assessment of the number of CD8 positive cells and the area occupied by them was subsequently carried out. As this representative selection of objects is shown in this picture. As a result of morphometric analysis performed in manual mode, the average number of CD8 positive cells in the center tumor was tissue was 103, Genotypic or 18,54. In the mucous membrane of the peritoneal region was 74,47, Genotypic 8,86. Significant difference between the regions were not found. In the same single and automatic population of the area occupied by CD8 positive cells in the last program was carried out. This indicator was 2,371, which take 397.8 in the center of the tumor tissue and 4,232 is a take of 503.5 in the important numbers and the differences were taking into account the obtained number of clinical and morphological characteristics, gastric cancer is significantly associated with the average area occupied by 38 different sites in different areas of the tumor. So a significant associated of high density concentration on the center part of the tumor. This low degree of tumor differentiation was revealed. The density of CD8 positive lymphocyte infiltration of morphologically non-morphosed areas is significantly associated with the presence of tumors angle in lymphatic vessels. Also, high density of CD8 positive lymphocyte infiltration of morphologically non-mucous areas is significantly associated with negative surgical margin of the reduction in gastric cancer with a great depth of tumor invasion and with a more advanced stage of the tumor process. So the main clinical and morphological characteristics of gastric cancer are given in this table. In conclusion, gastric cancer with more aggressive phenotype is characterized by a high density of CD8 positive lymphocyte infiltration of morphologically non-morphosed areas. In conclusion, in the course of this study, antibiotics was proposed to assess the degree of concentration of CD8 positive cells by tumor tissue and normal mucous membrane of the peritoneal region in gastric cancer. It is important that the process system for assessing the microenvironment is characterized by a moderate level of labor intensity due to use of an automatic morphometric analysis system, which also significantly increases the accuracy of the study and comparison with exclusively manual accounting method. Using this calculation method, it was found the assessment of microenvironment in areas of morphologically normal membrane of the peritoneal region is not significant prognostic size compared with the generally accepted assessment in the central part of the tumor tissue. So this book offers the method of assessing the degree of concentration of CD8 positive cells by morphologically normal mucous membrane of the peritoneal region in gastric cancer, which has high clinical value and prognostic significance. And thank you for attention.
My name is Endeavours. I am from Mongolia. I would like to thank for the Scientex Conference for giving me the opportunity to present my research article on this cancer stem cells and plant bioactive compounds. Larger cause of death worldwide. First, 33% heart disease. Second, 18% cancer. Third, 49% other diseases. Cancer is big Cancer is the leading cause of death worldwide. 18% of all deaths are due to cancer and estimated to reach 24.8 million cases in 2014, which is tend to increase by 14% comparing to 2020. Methods and method. We use the related studies and articles from the database and search engine, including PubMed, Central, Google Discover. Cancer conventional treatment are surgical therapy, radiotherapy, chemotherapy, and immunotherapy. These treatments are good effective, but have so many side effects, including high cost. Patients suffer a lot, various side effects for patients. Successful cancer treatment has not been achieved yet, although there has been progress. There is need to search a new approach which is less toxic, highly effective, and has low cost. A tumor is composed of cancer stem cells and cancer cells. Our conventional treatment is able to destroy cancer cells, but the main cancer stem cells are not destroyed. Therefore, cancer relapses. Maybe if we use cancer stem cells target therapy in combination with conventional treatment, we can cure cancer. Where is cancer stem cells? Cancer stem cells constitute the small immediately differentiation, tumorigenicity, post-treatment resistance, recurrence, and metastasis. Accurate and appropriate regulation of stem cell is important in normal biological process of the cell. It had been confirmed that several signaling pathways play important role in cell normal functions. There are 12 main pathways, and in some type of Hedgehog signaling pathway, the signaling pathway very important. Hedgehog signaling pathway leads to cell differentiation, growth, and determines embryonic normal function. On the other hand, due to an abnormal activation of the hedgehog pathway, cancer of brain, lung, prostate, lymphoma, gastric, and skin develop. Moreover, transforming adult stem cells to cancer stem cells. As a result, cancer and drug resistant can be developed. Sonic hedgehog signaling pathway is three ligand: sonic hedgehog, Indian hedgehog, and desert hedgehog. Has 12 receptors: PATH1, PATH2, K signaling converter is smoothness, and 3 of transcription factor GLI1, GLI2, GLI3. Mechanism of sonic hedgehog signaling pathway. Sonic hedgehog is attached to PATH1 receptor. Then smoothness is activated and GLI transcription factors is activated. The activated GLI is accumulated in nucleus and hedgehog target gene transcription. As a result, hedgehog signaling pathway is activated. Wnt signaling pathway. The signaling pathway and very important. The Wnt signaling pathway does not involve in normal physical functions of adult human animal, and it only involves in embryogenesis and cancer development. Wnt signaling pathway regulated embryonic cell migration, cell polarization, neuronal differentiation, organogenesis, and effect renewing of stem cell. Due to loss of normal Wnt signaling pathway regulation, embryogenesis interrupt cancer of breast, lung, gastric, lymphoma, melanoma, dermal cancer, and bone damage are developed. Wnt signaling pathway is divided to canonical and non-canonical. Canonical signaling pathway, Wnt protein complex is activated. Distraction complex is inhibited. Beta-catenin enters to cell nucleus freely, which activates TCP, F. As a result, gene expression gets improved. Beta-catenin, non-clinical. Due to deficiency of WNT protein, the Schwedfeld complex is not activated. Therefore, secondary protein complex, which are distraction complex, are activated and break beta-catenin. Nuclear factor kappa light chain in cancer of activated beta cell signaling pathway. Nuclear factor Kb controls cell inflammation, chain proliferation, angiogenesis, metastasis, resistant to chemotherapy and radiotherapy. Nuclear factor Kb is active in most of cancer cells, and the cell activation induces cancer cell growth, inhibits cell apoptosis, and induces angiogenesis. Tumor necrosis factor alpha induces cell death and inflammation mechanism. Tumor necrosis factor alpha is connected to cell surface receptor tumor necrosis factor 1. As a result, tumor necrosis factor receptor type 1 associated with domain protein, tumor necrosis factor receptor associated factor 2, inhibitor of apoptosis protein, receptor interaction protein kinase proteins are activated. As a result, inhibitor of nuclear factor kappa B kinase subunit alpha complex is activated. And due to that, inhibitor of kappa B deficiency occur. Due to the deficiency occur, inhibitor of kappa B, nuclear factor Kb enters to cell nucleus. Pre-inflammation gene, anti-apoptotic gene, and cytokines are released. Angiogenesis. Angiogenesis is the new vascular formation physiological process and also is the cancer cell prognostic general marker that indicated cancer prognosis, innovation, metastasis, growth, nutritional status, and oxygen supply. Mechanism of angiogenesis. Muscular endothelial growth factor induce angiogenesis of cancer. Due to VEGF is connected to VEGF receptor, MEV kinase signaling pathway is activated, and MMP, UPA are plasmin organ activator proteins are induced. By influence of VEGF signaling cascade in epithelial cell occur. VEGF are two activates cascade of tyrosine kinase signal and makes chance to create materially develop vessel, maintain transcription, growth, and survival. Immunology of cancer. The main goal of immunotherapy is eliminate cancer and reduce cancer mass. Immunotherapy inhibits cancer cell surface marker and dendritic, T, NK, CTL, NK cells, tumor necrosis factor alpha, interleukin 12, interferon gamma, interleukin 2, interleukin 7, cytokines. One of the protecting and survival methods of cancer cell is cell surface marker. The surface marker CD123 and CD44 are of particular interest. CD123. Excess growth of CD123 protein in cancer cell surface leads to drug resistance and ability of cancer development. CD123 is commonly detected in stem cell surface of neuronal, prostate, brain, colon, lung, liver, and ovarian cancer. CD44. CD44 is contained a bit or it does not contained in healthy individual. The excess detection of CD44 induces cancer stem cell growth and negatively affect the patient's prognosis. If CD44 is detected in cancer stem cell surface, commonly as a result, various types of treatment resistance occur. CD44 has an essential role to start, mark, hypo, beta, catenin, state 3 signaling pathway. Non-bioactive compounds. Since thousands of years ago, plants have been used for prevention and treatment of cancer-various diseases. The red emperor, also known as the ancient Chinese emperor, completed the first medicinal herbal literature, the Pensao, in 2800 BC. According to the World Health Organization, 65 to 18% of the population in developing countries use bioactive compounds from plants for primary health care. Recent studies in plant bioactive compounds are able to act against bacteria, virus, inhibit growth cancer cells, signaling pathways, and initiate apoptosis of cancerous cells. If we extract effective anti-tumor compounds from plant bioactive compounds and use them in combination with conventional treatments, it is possible that more progress will be made in cancer treatment. We have included on this slide about the anti-cancer biological services of some plants as an example. Veratrum californicum can be inhibited of hedgehog signaling pathway for prostate colon cancer. Artemisia annua can inhibit when the signaling pathway inhibit of signaling pathway for colorectal carcinogenesis. Kerba can inhibit multi-signaling pathway for prostate, lung, kidney, gastric cancer. Curcuma longa can inhibit of tumor necrosis, KB, for brain-breast cancer. Paclitaxel, which is extracted from bark sawyers in Pacific Ocean in the experimental model MDA-MB 231 xenograph. It inhibits CD133 and has effectiveness to inhibit cancer growth. But after stopping treatment, cancer develops faster. In ABC minus and plus mouse model, dasatinib and curcumin reduced cancer stem cell surface marker by 18 to 19%. Result and discussion. Currently, we are using cancer conventional therapy, gene therapy, anti-angiogenic therapy for patients with cancer. Cancer cells have stem cell population responsible for drug resistance and metastasis. Signal transduction pathways are associated to multiple types of cancer. Plant-based bioactive compounds decrease of cancer development risk and increase drug effects and inhibit several cancer stem cell signaling pathways in several tumors. Maybe if we completely eliminate the cancer stem cells, cancer cells are unable to grow up, therefore patients become able to die with their biological cause of death. Therefore, we need to explore the possibility of using plant bioactive compounds in the treatment of cancer patients. There are several issues we are confronting. These include, first, we need to test the mechanism and dose of action of plant-based bioactive compounds on cancer stem cells. Second, inhibition of signal transduction pathways has poor result if used solely, and interaction suitfulness of chemotherapy, drug, or other treatment targets should be determined. Third, we assume and that in future through clinical trial studies, an additional treatment strategy of using signal transduction inhibitors will be developed. Thank you very much for your attention.
TGF-beta1 genes in the HIV-infected type. However, as we have published more data recently, and I would like to add this data into this talk. So my talk would be association of the single nucleotide polymorphisms in cytokine and chemokine genes with the liver complication in Thai people living with HIV. And I'm going to focus on the SNPs in the interferon gamma, TGF-beta 1, and CXCL10, or another name, the interferon gamma inducible protein 10. Starting with the human immunodeficiency virus infection, or HIV infection, which is the underlying cause of the acquired immunodeficiency syndromes, or AIDS. This infection remains a leading public health issue globally, with the 39 million people living with HIV reported in 2022. Apparently, the AIDS-related deaths have decreased clearly. This is because of the introduction of the antiretroviral therapy, as shown in the increasing number of the HIV patients having antiretroviral therapy. Epidemic snapshot in Thailand also demonstrate the high number of the people living with HIV, and around 80% that receive antiretroviral therapy, and there is a trend of decreasing number of the AIDS-related deaths as well. This graph also show the increase of the people living with HIV that receive antiretroviral therapy, with a decreasing of the treatment gap shown in the graph. Despite effective ART, the chronic HIV infection can cause the persistent immune activation and inflammation, and this can cause non-AIDS comorbidities, and this together with some other factors such as lifestyle, age, genetic factors, and time of infection. Variety of non-AIDS comorbidity are observed, and such as the metabolic syndrome, the cardiovascular disease, and this includes the liver disease. Actually, liver disease is known as a leading cause of the illness and death among the people living with HIV, and apparently that an increased prevalence of the liver fibrosis, cirrhosis, and hepatocellular carcinoma in the people living with HIV group. Accumulating studies suggested that chronic liver disease in people living with HIV can be caused by multi-factors. Importantly, the co-infection with the hepatitis virus, the opportunistic infection, the immune activation, immune reconstitution, and also some regimens of the antiretroviral drugs. There's our previous studies, and together with others, have identified multiple risks for liver disease progression in people living with HIV. For example, the age, sex, CD4, cell count, HIV RNA levels, and the co-infection with the hepatitis C, and other factors. Apparently, the pathogenic mechanism for liver disease progression in people living with HIV is complicated and largely unclear, and the complex interaction between the factors HIV, ART, and others, including the immunogenetic factors, leads to more advances in diagnosis, treatment, and care of the people living with HIV. Looking at pathogenesis of liver disease in HIV infection, it is similar to the liver disease caused by other etiologies. And this process is triggered by hepatocyte injury or death, and this can be caused by the HIV replication in the liver, the co-infection with the hepatitis virus, and the antiretroviral therapy, and this can cause the damage of the hepatocyte and can cause the inflammation in the liver, involving the production of the variety of cytokines, and this can activate hepatic stellate cell to be differentiated as the myofibroblast cell, which is the cells that can produce extracellular matrix in the liver area and cause fibrosis or the scar in the liver. The pathogenic fibrosis can lead to the cirrhosis and hepatocellular carcinoma. The activation of hepatic stellate cell is the key event in the fibrogenesis, and this could be promoted by pro-fibrogenic mediators. Importantly, the transforming growth factor beta 1 and other growth factors, and also the reactive oxygen species, which is the product of the oxidative stress. The activation of the hepatic stellate cell could be promoted also by the function of the leukocyte in the liver area. The local macrophage, like named the Kupffer cells, also participate in this process. Some of the leukocytes, such as the T and B cell, can be recruited into the liver area. This is by the function of the chemokine system. Apparently, the cytokines and chemokines play a role in the progression of the liver disease, and in this study, we focus on the cytokine, the anti-fibrogenic interferon gamma, and the TGF-beta 1 cytokines, and one of the chemokines, interferon gamma inducible protein 10 or IP10. Another name is the CXCL10. The cytokine interferon gamma, TGF-beta 1, and the chemokine CXCL10 have been shown to play a role in the HIV disease progression and also participate in the liver disease. Interferon gamma, known as the T helper 1 cytokine that play roles in HIV progression to AIDS, and this cytokine can promote immune activation, the chronic immune activation in the stage of the AIDS. And also this cytokine known as the anti-fibrogenic cytokine that are found to be underexpressed during hepatitis and HIV infection. For the IP10 or CXCL10, this is chemokine that's secreted by various cell types in response to interferon gamma, and known to play roles in leukocyte recruitment and also immune activation in the liver. The chemokine can participate in the pathogenesis of liver disease caused by hepatitis B and hepatitis C. And looking at the TGF-beta 1, this is known as the master of fibrogenic factor that can drive the hepatic stellate cell activation and transdifferentiation into the myofibroblast and produce that extracellular matrix protein and cause the liver fibrosis. Apparently, in the era of the antiretroviral therapy, the role of these cytokines and chemokines require more clarification. Numerous studies also demonstrate association of the single nucleotide polymorphisms or SNP in the cytokine and chemokine genes with the HIV disease progression and liver disease. In this study, we focus on the well-established SNP in the interferon gamma, CXCL10, and TGF-beta1. The interferon gamma plus 874TA, which is the SNP located at the translation start site in the first intron, and apparently TT genotype is known to be associated with the increased production of the interferon gamma. This SNP has been shown to participate in the HIV disease progression and the clinical characteristics of the chronic hepatitis C. The SNP in the CXCL10 gene, the G-201A and the C-1596T, these are the two SNPs located at the promoter region of the gene, and apparently the haplotype TC, known to be the haplotype that regulates the production of the CXCL10, that is also known as the disease susceptible haplotype. This SNP, the two SNP, has been shown to play a role in the chronic hepatitis B progression. Looking at the TGF-beta1, and we have the minus 509 CT SNP, which located also in the promoter region and can cause the production of the TGF-beta as well. And it's been known that TT genotype is associated with high level of the TGF-beta 1 production. And for this SNP, there's been shown to be as a risk of the hepatocellular carcinoma in the chronic hepatitis C virus infection. Apparently, the potential influence of these SNPs in a liver disease that caused by HIV infection is still unclear, especially in the era of the antiretroviral therapy, and require more investigation. Our previous study have reported multiple factors that contribute to liver abnormality in Thai people living with HIV. We observe high prevalence of liver abnormalities assessed by transaminases and the liver fibrosis that assessed by FIB-4 score and the APRI. We also reported clinical features that affected the development of liver abnormalities, including age, gender, CD4 cell count, and the co-infection with the hepatitis B and C. We also reported the association of the genetic variation CXCL12G801A single nucleotide polymorphism with the significant liver fibrosis in HIV-infected Thai, so that the other immunogenic factors require more investigation. So that we hypothesize that the SNPs in the other cytokine and chemokines, the interferon gamma, CXCL10, and TGF-beta genes may influence liver fibrosis in Thai people living with HIV on long-term antiretroviral therapy, and aim to examine the genotypic and allelic frequencies of the SNP and the 4 SNPs in 3 genes in HIV-infected Thais. Also, we aim to analyze the association of these SNPs with the liver complication in Thai people living with HIV. This is a cross-sectional study performed in 200 HIV-infected subjects, and we recruit the patient who documented as HIV-infected person and exclude some of the patients who experience alcohol consumption, herbal medicine use, and steroid drug intake, and subjects who have opportunistic infection, especially the tuberculosis. We collected the medical records and the laboratory data, and we assessed the liver complication by assess transaminitis and the non-invasive method for measure liver fibrosis using the fibrosis marker, fibrosis 4 score, and the AST to platelet ratio index, or APRI. The blood sample were taken to SNP genotyping by the PCR-based methods, and also we perform the statistical analysis and where they are appropriated. This is the clinical characteristic of the HIV-infected patient recruited in this study. In this study group, we observed the high prevalence of the patient with co-infection with the hepatitis B and C. Also, high rates of the patient who develop liver abnormality, which assessed by the transaminitis and the liver fibrosis marker FIB4 and APRI. We then analyzed the association between the clinical characteristic noted in the table and the liver abnormalities that assessed by the transaminitis and also liver fibrosis by FIB4 score. Apparently, we observed no significant association between the features, clinical features with the transaminitis except the gender. For the liver fibrosis by FIB4 score, we observed that the age and gender are identified as the risk factor for the development of liver fibrosis by FIB4 score, and we found that there are protective factors which the CD4 cell count and also the treatment by antiretroviral therapy longer than 6 months as the two factors as protective factor for the development of liver fibrosis. We perform the SNP genotyping by PCR-based methods and confirm the result in the 10% of the sample by direct sequencing. The picture shows the PCR SSP for of the interferon gamma SNP, PCR RFLP for the CXCL10 SNPs, ARMS PCR for the TGF beta 1 SNPs. By doing this method, we obtain the genotypes of the each SNPs, and all the genotyping we confirm by the direct sequencing shown in the picture. This is the data showing frequencies and association of the SNPs with the liver abnormalities. We reported the frequency of the genotypes and alleles of the SNP of interferon gamma, CXCL10, and the TGF beta 1. Also, we analyzed the association of the genotypes and alleles with the liver abnormalities assessed by transaminitis and the liver fibrosis by FIB4 score. Apparently, there is no statistically significant relationship between the genotypes and alleles with the outcome transaminitis and liver fibrosis by FIB4 score. Then come to the discussion. We performed the study in the patient groups with the high prevalence of the liver abnormality that are as the transaminitis and the significant liver fibrosis. We also observe the high rates of the co-infection with the hepatitis B and C, and also we have quite a high percentage of the patient with longer than 6-month exposure to ART. The characterization of the patient by uni and variate logistic regression also indicated the multi-factors that contributing to liver abnormalities in this study group, and they are quite consistent with our previous study. In this study, we also reported the genotypic allelic distribution of the 4 SNPs in Thai people living with HIV, which may provide immunogenetic data that potentially preferable to inflammation-related disease. Next, even though the SNP tested in this study and have been shown to play a role in other diseases, there is no statistically significant association of the all SNPs with the liver abnormalities in this study group. It is possibly due to the influence of the multiple factors that may be involved in the disease progression, especially the exposure to the antiretroviral therapy. And this is consistent with the finding in our previous study that we observed the lessened impact of the genetic determinant, the SNP in the CXCL12 chemokine G801A, that also observed in the patient who naive to the antiretroviral therapy. However, there is the limitation of this study as a cross-sectional study with a small number of the subject and uncontrollable confounding factor, and we also haven't performed the functional assessment of the SNP genotypes. And further studies is warranted to study on the interferon gamma CXCL10 and TGF-beta1 levels in the liver tissue and also the circulation. Okay. Next, to summarize our finding, we previously reported the multi-factors that involve in the liver abnormalities in HIV infection. Also, we attempt to determine the immunogenetic determinants in the liver complication during HIV infection, and we observed that only the CXCL12 G801A SNP that exhibit the positive correlation with the liver fibrosis. This is especially in the group that naive to the antiretroviral therapy. So we may suggest that the influence of the immunogenetic factors may be lessened by the other multi-factors, especially antiretroviral therapy. So by treatment with the antiretroviral drugs, not only suppress the viral replication, but also can maintain the immune status, and this will be the data support the diagnosis, treatment, and care of people living with HIV with the long-term suppressive ART. Lastly, many thanks to my colleagues and funding agency, and any suggestion and comments would be very welcome. You can contact me by this email, and thank you for your kind attention.
Okay, so that was a interesting talk about how in Thailand or the the viruses of immunodeficiency is working on the liver. As you can see, this is a radiological images. This is galactography. So in a patient that has the suspicion of a breast cancer but intraductal, with some needle, a contrast is introduced in the nipple. So afterwards, a mammogram is made, and you can observe how the ducts are filled with contrast. And if there is a field defect, like in the images, you can see the arrows that are pointing that there is no filling of a duct because there is some tumor occupying the duct. And I cannot see because the image is too small about the algorithm. Can you zoom it? It will be nice to see it. Yes, there you see the image. A needle is made through the nipple, and you can see how the contrast is pulled in. That's opaque contrast. Normally, it's a painful procedure, but it's necessary to do it. And you see down there the schematic of the duct and how the tumor develops in the duct. And can we see down more? Okay. And can you, okay, so here's the mammogram. You can see it on your right side. You see the mammogram with a little bit of contrast. And can you zoom it in, please, more? And I will explain a little bit about the diagnostic algorithm. Okay. The most important thing is the physical examination, the age, the planes, the anamnesis, palpation, visual assessments of secretion, smear imprints, selection of first-line technique, mammogram or ultrasound. Ultrasound up to 40 years and with palpable nodes, mammogram from 40 years old. I have to say that you can combine them. Depending if the woman is more than 35 years old, you can do both of them and see the ultrasound, you know that it can be done if you have the equipment. And afterwards, if you identify that you have a dilated duct, you can do a ductal lavage and you can see it on the microscope. And if it's negative for pathology, depending on how high is the suspicious of diagnostic, you can give it a controlled, or you can do a more diagnostic procedures. So here you can have the interventional with core needle biopsy under ultrasound or mammogram control, depending of where you can see the lesion at first. And afterwards, we can see the ductectomy with double marking with metal fire. Okay, that's for you can have the surgeons, you can put the fires or the bracketing, and exactly where you see the difference, or where you see the lump with the ductography, and you can help the surgeon not to excise all the breast, just the little part that it's causing this obstruction. Okay, so do you have any questions about this poster? Okay, I see none. Okay, can we pass to the next poster, please? Okay, we have the next poster by